Well, we don't make any progress in finding new treatments unless we have well-validated, reliable measures of the severity of dystonia. And so our first speaker will be Gianni Defazio talking about rating scales. Gianni, take it away.
Dystonia is now recognized as a complex condition characterized by both motor and non-motor components. Non-motor symptoms may be represented by sensory abnormalities as well as psychiatric and cognitive problems. The whole spectrum of research on dystonia, from basic pathophysiology to clinical management, depends critically on our ability to measure the symptoms. Several different rating scales have been proposed to evaluate the clinical aspects of dystonia. These scales belong to 4 categories: motor, disability, quality of life, and unified scales. To check a scale for validity, several clinimetric or measurement properties need to be assessed. Some measurement properties, like reliability, refer to the ability of the tool to support multi-rater and multi-center studies. Other properties refer to the internal structure of the scale, that is, the relationship among individual items, the degree to which the scale describes the condition under study, and the ability of the scale to measure a change in state. This slide summarizes the scales currently in use for evaluating the clinical aspects of dystonia. As you can see, there are scales designed to rate dystonia in several body parts and scales designed to approach focal dystonia. Focusing on generalized dystonia, it can be observed that none of the proposed motor rating scale has been rigorously tested for clinimetric properties. Validity studies focused on inter-rater agreement, internal consistency, to see whether several items that assess the same general construct produce similar scores, and convergent validity, that is the degree to which 2 scales that theoretically should be related are in fact related. Other relevant properties, like for instance responsivity to change, were not checked. Motor, disability, and quality of life scales have been proposed for blepharospasm, whereas a comprehensive scale is to date lacking for this condition. As highlighted for generalized dystonia, most blepharospasm scales were characterized by incomplete clinimetric assessment that, however, also included responsivity to change. Only the most recent motor scale, the blepharospasm severity rating scale, the BSRS, provided exhaustive clinimetric assessment. Since cervical dystonia is considered the most frequent focal dystonia, it is not surprising that several scales were developed for cervical dystonia and that a greater effort was made for assessing their validity, even though clinimetric assessment was again incomplete. The recently developed comprehensive cervical dystonia rating scale includes measures for motor severity, disability, pain, psychiatric aspects, and quality of life. Certainly, this is not an easy-to-use tool, but this unified scale can be applied as a complete scale or in modular format. A disability scale and a unified scale have been proposed as specific tools for rating oromandibular dystonia. The unified scale, also called oromandibular dystonia rating scale, the last line of this slide, was based on 3 sections. An examiner rated scale that included 3 subscales for severity, disability, and pain. A patient-administered questionnaire based on clinically relevant aspects of oromandibular dystonia like eating, speech, cosmetic, and social family life. And finally, 4 subscales of the cervical dystonia impact profile 58, measuring sleep, annoyance, mood, and psychosocial functioning. As for other focal dystonias, assessment of clinimetric properties of the disability and the unified scale was incomplete. However, both scales yielded acceptable levels of reliability, internal consistency, discriminant convergent validity, and responsivity to change. Only 2 scales have been proposed for limb dystonia, namely upper limb dystonia. The paucity of proposals and the very limited clinimetric assessment probably reflect the variety and complexity of dystonic movements postures characterizing these focal dystonia. Overall, this overview would suggest that most rating scales used at present have not been rigorously tested for clinimetric properties. Testing other relevant clinimetric aspects like responsivity to change is therefore necessary to better delineate the clinical utility of the scales. Recently, the P4 project, Diagnostic and Rating Tools for Blepharospasm, provided the unique opportunity to assess measurement properties of 4 clinical scales rating the motor severity of blepharospasm in the same large patient population using the same observers. There were the Bark von Marsden scale, the Global Dystonia Rating Scale, the Jankovic Rating Scale, and the Blepharospasm Severity Rating Scale. The aim was to obtain information to drive the choice of the scale to be used to assess blepharospasm by many investigators in many centers. In this regard, exhaustive clinimetric assessment showed that the Bark von Marsden scale has unsatisfactory clinimetric properties when used for assessing blepharospasm motor severity alone. The Global Dystonia Rating Scale has acceptable clinimetric properties, and the Jankovic Rating Scale and the Blepharospasm Severity Rating Scale have both satisfactory clinimetric properties. With regard to the latter 2 scales, however, examination of the score distribution curves indicated that blepharospasm related disability as expressed by the blepharospasm disability index in the upper part of this slide adhere more accurately to the blepharospasm severity rating scale than to the Jankovic rating scale. Based on available clinimetric information, scales highlighted in red, here there is a mistake, the Global Dystonia Rating Scale should be highlighted in red, not the Bark von Marsden scale. However, scales highlighted in red should provide a better performance. The working context and aims, as well as the easy to use, should also drive the choice of the scale to be used to assess dystonia. Future directions will include refinement of existing rating scale, development and validation of new tools for oromandibular dystonia and arm dystonia. Validation needs to be performed in multi-center populations. Development of comprehensive scales, including focusing on both motor and non-motor features. And last not least, development of teaching tapes demonstrating the ratings for each body part to increase reliability. Thank you for the attention.
Thank you very much, Giovanni. This is now open for questions. I don't see anything yet in the chat or in the Q&A. It was a terrific overview of the established scales and trying to move forward. While we're waiting for a question, I have a question for you then, Giovanni. So one of the challenges that you point out in developing scales is knowing how they respond to changes in severity. And that's really challenging in this particular case. And many times it's done just cross-sectionally by trying to see different severities and then looking at convergence with other measures of severity. But is there a way to try to do that within a subject with a treatment, such as looking at how botulinum affects these things and doing it at different levels to see whether there's flooring effects or sealing effects in that particular
area? Yes, thanks for the question. You are right. Sensitivity to change is crucial for a scale to be used in clinical practice and research, but it is not the only features that we need to take into account. In this regard, item, for example, as you item to total correlation or the floor and ceiling effect are relevant, important features to assess in a scale. And several of the most used rating scales, for example, rating scales for generalized dystonia that are widely used for DBS assessment, for example, lack these assessment.
Okay, thank you very much. That's a very important point.
You're welcome.
For the application of these. Any other questions? Many? Any others? One coming through here. Let's see. What is needed to test a scale for sensitivity to change? That's from Buzz Jinna.
Obviously, we need an effective treatment or conditions that we know that modify the motor severity or other types of severity. And this is we need to assess the condition before and after treatment, before on the or after the changing condition. In this regard, I would like to say that it may be important to highlight changes. The complexity of the scales. In other words, scales with a wider range of score values probably are can make evident more discrete changes than scales with a few a limited range of score values.
Right. Dynamic range is what you're pointing out, and that's very important. We have a sufficient dynamic range. Mark Hallett points out that Sarah will talk later about PRO scales that are important, and how do those motor type scales correlate with PROs, I guess will be something that will address this particular issue, because it'll give us more variability within this subject. And another attendee is just, I'm not sure there was a question in there, but it was a comment. Here's a question: is it better to focus on motor or the disability aspect of the scales in blepharospasm, or is that not as applicable? And that's from an anonymous attendee.
I think it may depend on the setting in which we would like to use a scale. For example, in clinical practice, it may be more useful, an easy to use tool than a more complex scale.
Mm-hmm. Other comments? Anything else? So we know that the dynamic range, it is really important in doing and identifying change. And this is going to be challenging differently for the different kinds of dystonia. Which kinds do you think are more challenging for determining change? Do you think it's cervical, bleph, laryngeal? Do you think that makes a difference?
It's a difficult question because dystonia is a complex condition with several aspects. It is, but I think that yes, dystonia is a complex condition, but some dystonias, such as blepharospasm, for example, are apparently more simple than cervical dystonia or upper limb dystonia with regard to clinical features. And in this, so it may be easier to design a scale to measure blepharospasm than the various aspects of cervical dystonia. The relevance of each aspect depends on the individual subject carrying that particular dystonia, I think.
Thank you. Cindy Camella asked, do you think that automated computer-based techniques will replace clinical evaluations?
It is possible. Automated computer-based techniques would be particularly useful to assess patients at their homes, for example, within a real-life situation. And in this regard, it would be very useful, I think.
Thank you. And part of that is going to be how well we can teach such programs, which comes back to your other point, and that is teaching tapes. Whether we teach a computer or we teach the individual rater, those are still, we have to be able to characterize the dystonia sufficiently well to be able to promulgate that expertise in order to implement the scale in a reasonable way. That's very hard. Other comments? Okay. Well, that was a terrific review of the various scales and the challenges that we have with scale development, including not just the motor features, but the non-motor features as well, and all the various issues.